Good morning, everyone. Yeah. Thank you, Chair, for the introduction. So our study title is The Incidence of Intimate Partner Violence and Associated Risk Factors Among Pregnant and Breastfeeding Women Living with HIV in Malawi. So this study was funded by the NIH. It's an RR01 study. And we just also want to appreciate the organizers of this conference for allowing us the opportunity to present our study. We have no competing interest to disclose. So for the background, as we're aware, intimate partner violence, in short, IPV, is a significant global public health problem and is more common among women living with HIV. And the prevalence and incidence of IPV is higher among pregnant women living with HIV. Also, IPV has been shown to be associated with the suboptimal treatment outcomes, which includes poor ART adherence and unsuppressed viral load. As a result, we noted that IPV has adverse consequences on the health of both the mother and the baby during pregnancy. And also, when we looked at the literature, we noted that the majority of studies that focus on IPV prevalence and incidence amongst women have been from resource-rich countries. Therefore, research examining the incidence of IPV amongst pregnant women living with HIV and associated risk factors from low and middle-income country setting is scarce. And to our knowledge, there is currently no published research examining the incidence of and the risk factors associated with the IPV amongst pregnant women living with HIV in Malawi. Therefore, this calls for further research to describe the incidence of IPV in pregnant women living with HIV in Malawi. Therefore, our study objective is to examine the incidence of IPV and its associated risk factors amongst pregnant women living with HIV in Malawi. So for the study methods, the study that I'm presenting today is derived from a multi-site randomized control trial that looked at the impact, implementation, and cost-effectiveness of a novel video-based intervention which we call VitalStart, which is delivered to pregnant women at antenatal clinics in Malawi. So for the data that I'm going to present today, we collected it from October 2018 to December 2021. And we had 3 peri-urban study sites, and we conducted this study in 2 districts, the Lilongwe district and the Mangochi district. So in Lilongwe, we had 2 health facilities, while in Mangochi we had 1. We selected these 3 facilities based on the HIV ANC prevalence at these 3 facilities. So we defined IPV as any first time or new experience of IPV that occurred in the 12-month period after the baseline visit amongst the study participants. For this, what we did was we were asking respondents, which is the pregnant women living with HIV, if they ever experienced a specific act of IPV from their most current or recent partner in between the surveys. So we looked at between baseline and month 1, and then month 1 and month 6, and also we looked at the incidence between month 6 and month 12. So we collected self-reported IPV data from the women at the 3 follow-up time points, which is the month 1, month 6, and month 12 visits. And we assessed IPV using the widely validated WHO Violence Against Women questionnaire, which consists of 13 items in the 3 categories of IPV, which looked at physical violence, emotional violence, and sexual violence. So the 13 items just consisted of questions with yes and no responses, which investigated whether participants had experienced specific acts of violence perpetrated by an intimate partner since their previous study-related visits. So for physical violence, we had 4 questions that evaluated physical violence that looked at whether the women were physically assaulted by their intimate partner. And for emotional violence, we evaluated it using 6 questions, which looked at whether the woman was belittled, insulted, or threatened by their intimate partner. For sexual violence, it was evaluated using 3 questions that looked at whether the woman was asked to do anything sexual that they were not comfortable with by their intimate partner. And for IPV incidents and follow-up, it was modeled using the generalized linear model. And then we also examined the risk factors associated with IPV, and these included depression, alcohol and substance abuse, and the woman's age. So for these risk factors, what we did was we just looked at the literature in a similar population and what risk factors other studies have reported. So those are the risk factors that we also looked at in terms of our population. For the results, data from 455 pregnant women living with HIV from all the 3 sites that I mentioned earlier, who had a partner and were continuously enrolled in the VitalStat study for 12 months. And in terms of the age, the mean age for the participants was 27.8. And we had 81% out of the 455 who were literate, and we had 54% who had no primary education out of the 455 women that we looked at. In terms of the prevalence of IPV, we found out that it was at 43%. So when we looked at the incidence of IPV amongst the pregnant women living with HIV in our cohort at the follow-up time periods, what we found out was that at month 1, the incidence was 7%, at month 6, it was 4%, at month 12, it was also 4%. Therefore, it was indicating that the IPV prevalence was high during the 12-month period in our study. When we looked at the risk factors for the incidence of IPV overall, we found out that depression and alcohol abuse were shown to be associated with the incidence of IPV. And these are the ones that we included in the multivariate model, and we found out that they were still significant to be risk factors for incidence of IPV. What we did as well is to look at IPV type overall. So we found out that emotional IPV was the most common type of abuse with an incidence of 9%, while physical and sexual violence had an incidence of 4%. What do we conclude? So in conclusion, what we realize is that IPV is a significant public health problem amongst the pregnant women living with HIV in our community. And the incidence of IPV during pregnancy amongst these women was high, with emotional violence experienced by many women. Therefore, what we are proposing is that when we're offering interventions to pregnant women with HIV, it should be interventions to prevent, detect and treat trauma alongside HIV services for these women as optimal care for them. In conclusion, also just like to acknowledge and thank our study participants who took part in this study from all the 3 sites. We have our Vital Start team, which is being led by 3 research officers, Mtisuge, Angela, and Innocent. And we also like to appreciate the Ministry of Health, the Tingate program team, Baylor College of Medicine, the Baylor family, and also, as I mentioned earlier, NIH for funding this study, and also USAID, which supports the Tingate program. Thank you. Thank you.